Q&A from the committee. Okay?
Sure.
Okay, go ahead.
Good afternoon, everyone. First of all, thanks everyone for committee member to come on my oral defense. So, my presentation, my topic is patient-specific computational fluid dynamics, modeling for the advanced hemodynamic assessment in cardiovascular and cerebrovascular disease. So we are going to begin with the outline, the main goal of our research, in which we talk about interaction of computational fluid dynamics, coronary artery disease, intracranial artery aneurysm, hypothesis, experiment, methodology, result, discussion, conclusion, and future direction. So far with this thesis publication, the core of this thesis is based on 4 research articles, all of which I will go through in detail. So first paper is already published in the Journal of X-ray of Science and Technology, Computational Fluid Dynamics, Modeling of Coronary Artery Blood Flow using OpenFOAM, validation with the Food and Drug Administrative benchmark nozzle model. And on on the cardiovascular, another paper is in progress in which computational fluid dynamic of coronary artery stenosis, systolic flow impairment, evaluating wall shear stress gradients, and LAD specific vulnerability for 3D CT and CFD. And one paper is published on medical physics on the cerebrovascular disease, in which the localized hemodynamic assessment and rupture risk evaluation of intracranial aneurysm using the Tesla framework by computational fluid dynamics. And one paper is in progress on the cerebrovascular disease is progressive flow abnormalities in cerebral aneurysm development, comparative analysis, normal, ballast, secular, and rupture hemodynamics. So hypothesis is this study hypothesis that using computational simulation with pulsatile flow pattern to analyze the hemodynamic parameter can enhance the understanding of intracranial artery aneurysm and coronary artery disease. By combining the CT and MRI image with CFD simulation, we aim to improve the diagnostic accuracy and develop more effectively personalizing treatment for IAA and CAT, leading to better patient outcome and more precise clinical decision making. So first we go brief discussion about the history of the computational fluid dynamics. The first person is known as Lewis Frey Richardson. The first attempt to calculate the fluid flow was set forth for the application for weather prediction. He envisioned the forecast factory that labeled with 64,000 human computers. His method involved the inputting weather observation data to the corresponding grid location, then solving the forward step equation. So here is like a geometry. In here the earth is considered as a geometry, and meshing the main number of the computers, like he used almost 64,000, and I just showing the number of computer and meshing. And the boundary condition, like each computer has boundary condition. For example, if they want to elevate the weather, the speed of the wind, of the temperature, so different weather like boundaries they will select on this setting. So after that mesh solver, so they will send this to the main center for the solver control. So obtain the solution time steps. So each time steps, if they every 5 minutes they send the data, maybe the workload is more, but the accuracy is high. So if they send every 1 hour the information from each computer to the solver, but the time is fast, but the accuracy may be low. So these are the simulation time step and this method that he used. So if you see the history, Lewis Frey Richardson in 1940 proposed the numerical method for solving partial differential equation that describe the fluid flow. And in 1950s, digital computer make it possible to perform more complex calculation and simulation. John van Neumann and Stanislaw Alma introduced the new numerical method for CFD. In 1970s, the first practical CFD software is introduced by the companies such as McDonnell, Douglas, and IBM. In 1980s, the development of the visualization tools allow the engineer to see the result of simulation in 3D. In 1990s, rise the parallel computing made it possible to simulate large and more complex fluid flow. In 2000s, computer and high performance computing make it possible to perform simulation then were thought to be impossible. So the possibilities of the CFD in 21st centuries in different environment they're using, like environment studies, aerospace engineering, high performance vehicle designing. And in biomedical research, simulate blood flow in the human body, aids understanding of the disease like stenosis, aneurysm, strokes. So lead to the new treatment and surgical procedures. So if we, here I show the anatomy of the coronary artery and the intracranial artery. These two are using for my simulation and research. Why I choose this one? Because if you see annually global death according to the World Health Organization 2025, the annual global death is 9 million with the coronary artery disease. And with the stroke is around 7.3 million. If we see the percentage, 13% percentage of global death due to the coronary arteries. And with the stroke, it's 9%. So the common risk factor are hypertension, smoking, family history. But especially linked with the intracranial artery is a connective tissue disorder and polycystic kidney disease. And with the coronary artery disease, unhealthy diet and the physical inactivities are the risk factor for coronary artery disease. So in our methodology for the coronary artery disease, we use the CT scan images which were 3D reconstructed using space clamp and geometry refinement in the space clamp, and using ISM we use the extended tube, and in the ISM we generated the mesh generation. For the CFD simulation we use the pulsatile flow, and after that analysis. So this is the graphical abstract of my paper that I published, in which normal, mild, moderate severe stenosis, we take the DICOM images, reconstruction and vessel segmentation, meshing and pulsatile flow, and we analyze the hemodynamic parameter, in which wall shear, wall pressure gradients, fraction for reserve, vorticity, wall shear stress, time average wall shear stress, oscillative shear index, and relative resident time calculation. So in which we peak systolic change versus the normal in the pressure is decrease, and velocity, wall shear stress, and vorticity increase, which show the most prominence at systolic. And the special biomarker at the throat, wall shear stress and pressure gradient are increased, and at distal after stenosis, OSI and RRT is increased, which show the stenosis center and flow instability distally. And artery specific finding, we also, the normal cases we compare LAD, RCA and LCX, in which LAD is 0.83 and RCA 0.88 and LCX 0.93, which show the LAD is vulnerable for the ischemia, because the 0.85 almost 85 in LAD, so it means the stenosis have more chance to in LAD comparing to RCA and LCA. So clinically it faces specific threshold and wall shear guarding PCI. So in cerebrovascular artery, we use the MRI images, and the steps is almost same like 3D reconstruction, and refine it and extended tube, mesh generation, CFD simulation. We use the pulsatile flow of internal carotid artery. After that, hemodynamic analysis. So this is the graphical abstract of my intracranial artery first paper. So in which we use the MRI images, and we use ultrasound Doppler ultrasound of the carotid to get this waveform. After that, we also use the same process and extended tube meshing, everything, and we find the hemodynamic variation like pulse and flow carried stress and turbulence within the aneurysm, low wall shear weakness wall, while the high wall shear causes the mechanical stress. Elevated OSI, prolonged RRT indicate endothelial dysfunction, and flow stasis increase the rupture of risk. Rupture aneurysm show higher wall shear stress, OSI, and vorticity, highlighting the need for the dome-specific hemodynamic analysis. The Tesla framework, the target elevation for synergic link in aneurysm, Tesla framework, review the spatial variation in dependence of wall shear stress, TOS, OSI, and RRT. Elevated wall shear stress slip the PG mark and stress zone, while the low wall shear stress with and high RRT indicate low stasis and vulnerability. Unique OSI RRT patient emphasized Tesla wave is accessing rupture risk. In clinical application, localized hemodynamic mapping is critical for rupture risk prediction. The Tesla framework enables the personalized risk assessment and targeted therapies. Future work should expand sample study, temporarily change, and integrate a Tesla matrix with the clinical data for better prediction. In conclusion, this study provides the key insight of complex interaction hemodynamic parameter in intracranial aneurysm. By pinpointing the localized stress and flow extreme, it underscores the role in the rupture risk. The Tesla framework offers powerful approach to enhance the aneurysm elevation and guide clinical decision. So I measured the different hemodynamic parameters. So in later we're going to talk about high value and low value. So what effect of the high value versus low value? So if in the pressure, if the value is very high, in the CAD, coronary artery disease, suggests possible stenosis or downstream resistance can lead to increase the myocardium workload. And in the IA, intracranial aneurysm, contribute the wall dilation and maybe promote aneurysm growth or rupture. If it's low, pressure is low, the CAD indicate distal perfusion deficit and downstream ischemia. And in IA, may reduce the wall stress to low and signal flow diversion or poor perfusion. Velocity. If the velocity is high, the CAD sign to narrow lumen and jet flow through the stenotic region. And in IA, high velocity jet aneurysm neck can cause the focal wall stress and link to the rupture. And if the velocity is low, can indicate poor perfusion distal to the stenosis and stagnation zone. And in IA, promote the blood stasis within the sac, linked to the thrombus formation and wall degeneration. And if the wall shear stress is high, the CAD found near the stenosis throat may be cause endothelium damage if excessive. IA, high wall shear stress is linked to aneurysm initiated by damping the endothelium, damaging endothelium. And if the wall shear stress is low, promote the atherogenesis like a pulp formation, and IA associated with the aneurysm growth and rupture due to the wall remodeling and inflammation. And the TOS both in the CAD and IA have generally protective, indicate a consistent flow that maintain the endothelium if it's a high. And if it's a low, CAD link to the plug progression and vulnerability. IA suggests risk of aneurysm enlargement and rupture due to the chronic low mechanical stimuli. OSI, if OSI is high, CAD indicate the disturbance or oscillatory flow associated with the plug prone region. And IA, high OSI near to link to the rupture prone aneurysm, irregular and unstable flow. And if it's a low, both in CAD and IA predict unidirectional flow and generally protective. So RRT, if it's high, in CAD promote lipid accumulation and plug instability. And in IA, blood stagnation in the sac and wall weakening and thrombus formation. And if it's a low, short resonance time, efficiency, blood flushing, and it's protective. So pressure gradient. If the pressure gradient is a high, CAD strong indicator of the flow limit stenosis used in FFR or IFR. And IA may indicate forceful inflow jet correlated with the higher rupture risk. And if it's low, the normal or mildly diseased segment. And IA less aggressive inflow but also main stagnation. So vorticity. If the vorticity is high, indicate complex flow near the bifurcation or stenosis may affect the shear stress patterns. IA vortex structure in the sac correlate with the rupture prone geometries. In vorticity if low, both in CAT and IA, stable flow less likely to cause chaotic stress on the wall. So first we do the grid independent test, in which we have a core mesh, median mesh and the fine mesh. And also we check the simulation time. So its simulation time is 5.53 hours. Course is 5.3 hours. And the simulation in the median is 67 hours. And simulation in the fine is 93 hours. And when we check the relative error between the course and median is very high, like 4.1%, but in the average fine to median is 1.31%. So in our simulation we use the median meshing for our simulation. So first we're going to discuss about first section that paper we published. It's a computational fluid dynamic modeling of the coronary artery flow using open form validation with the food and drug administrative benchmark model. So first of all, we've measured the fraction flow reserve, in which it's a division of pressure distal divided by pressure proximal, and we measured the stenosis at the center of the stenosis, velocity at the center of the velocity at the center of stenosis. So we see it's inversely proportional to each other. So you can see it's if the FFR value is the high, the velocity is low, and if you see case which is the severe stenosis, the FFR value is very low and the central velocity is very high. So it's showing the inverse proportion. After that, we also check what happened, because interventional coronary angiography, they will measure at 20 mm from the stenosis and after the stenosis. So in which we check also at different distance, like 10 mm to 30 mm. So when we check, when increasing the distance, the value is going to decrease. So therefore, so it's mean that we need a specific standardized distance to measure the FFR value. So after that, here is I comparing about the mild stenosis, moderate stenosis and severe stenosis, in which I showing the image of DICOM image, the location of the stenosis of all three cases, and also measuring the FFR value. So FFR value in the mild is 0.86 and FFR in the moderate is 0.60, and in the severe case it's 0.3. So from here also we can say, like with the computational fluid dynamics, we can find the stenosis with FFR value. And with the grading, if grade 1 is like a normal, grade 1 is a minimal, grade 2 is a mild, and grade 3 is a moderate, and grade 4 is a severe, and grade 5 is a almost totally occlusion. So when we see with the grading, FFR value is decreased with the grading. If the very high stenosis, the FFR value is decreased, and when we see the velocity is increased with the grade of the stenosis increase. So that one first one, and second which is under progress is the computational dynamic phenotyping of coronary stenosis, systolic flow impairment, elevated wall shear gradient, and LAD specific vulnerability for the 3D CT and CFD. So this table show the detail about the number of the cases and its area, parameter, and extended tube length. in which LCA, LAD, RCA, LAD, and LCX, and also measuring, showing the number of the element in the meshing and number of the nodes, and also show the simulation time odds. So after that we checking the pulsatile flow effect on the different location, which is the LF, left main coronary artery, and LAD proximal and distal, RCA proximal and distal, and LCX proximal and distal. And when we check the pressure, in which showing the same effect of the pulsatile flow. But in the pressure, the LAD distal showing low pressure as compared to other. And in the when we see the velocity, the RCA distal show, LAD distal showing high velocity. And when we check the FFR value of RCA, LAD, and LCX, so it's the wave pulsatile flow showing the effect, and it's affecting the pulsatile flow on simulation. So this one I showing the animation of the velocity. So I follow like showing all this is the right coronary artery, and this is this is left coronary artery, and it's right coronary artery. So I'm showing how the pulsatile flow affecting, like a wall shear stress. If you see the here the bifurcation is showing very high wall shear stress when it's reached on the peak, and on the distal peak also. So it's showing the effect of the wall shear stress on the moderate, and in this one also like a RCA showing the effect of wall shear stress. Yeah. So here is like a stenosis, so it's showing high peak systolic and the diastolic effect on the wall. So after that I measured FFR value at the starting of the cycle, early systolic, peak systolic, late systolic dichotic notch, early diastolic shoulder, so at different phase point in the pulsatile flow. So after that, when we see which coronary artery has FFR value high, so LAD is showing a low FFR value comparing to LCX and RCA. And after that, we have a time average wall shear stress. So because time average is the average of the pulsatile flow, so we don't have pulsatile flow effect in this one. And I show the case, 3 cases that showing a high time toss at this location. And in this one, showing the oscillative shear index across 3 hemodynamic cases, like case 1. And case 1 I show where is the high OSI on the bifurcation, and in this another case 2 also showing like a bifurcation the OSI is high, and in RCA at the end, almost at the end of the right coronary artery showing the high OSI. Like you can see this area and this area. So after that I measured the relative resistance time RRT across 3 cases of RCA and LAD. So it's also showing high at the bifurcation area, and the same trending on the end of the RCA. So after that, in this one we comparing the normal, mild, and moderate stenosis at different phases. So so small. So if here is okay, this one is okay. Yeah. So in this one, when you're comparing the pressure, the normal in normal the pressure is very high in the normal, and in the severe the pressure is low. But when we see the velocity in the severe cases, the velocity is very high, and moderate is after high, then moderate, a moderate one. So the velocity is very low in the normal cases. And when we see the wall shear stress, also the wall shear stress, pressure gradient, and the vorticity, the severe case is showing the high values, and after severe, then moderate, then mild, and then the normal cases. So after that we see the relative difference between different like a normal, mild, moderate, and severe. So when we take a normal as a reference, and when we measure in the mild, like you can see in the pressure, it's a minus, is going to the decrease. But if we see the velocity, it's high, increasing, like 26, 48, 68. And also wall shear stress is increasing, like 10%, 39%, and 65. And the vorticity increasing 33%, 117, and 114%. And if we see the pressure gradient, 83%, 122%, and 136%. So the relative changes difference is also high in as increase in the stenosis gradient. So after that we measure the pressure normal, mild, moderate, and severe at a systolic and diastolic before the stenosis, center of the stenosis, and after stenosis. So with the before and after we can get the FFR value, and with before stenosis and center we can get the pressure gradients, wall shear stress gradients, and center and after we get the wall shear stress gradient negative. So this table shows that in the normal the wall shear FFR value is very high because the threshold is 0.8, and in the mild cases is around the 0.8, and in the moderate it's very low, and in the severe is also showing low. So this is used for the FFR. And the wall shear stress gradient before stenosis and the center of stenosis. So we compare between the systolic and diastolic. So increasing the wall shear stress gradient is increased, and after stenosis the value is also decreasing from center of stenosis, and after wall shear stress gradient is decreasing with the increasing the level of the stenosis. So we measure like a before stenosis, center of stenosis, and after stenosis that value. And we also measure same value in the TOS, RRT, and OSI. Yeah, so normal, mild, moderate, and severe. So center, if we see it's increasing with stenosis, like a severe stenosis is 35.06 and the normal is 5.35. So this one is like time erosion. Sorry, it's reflecting there. So it's a time error wall shear stress and a relative reference time RRT in scan reported for proximal, stenotic, center, and distal, and under the varying stenosis severities, value expressed in the mean standard deviation and computational fluid dynamics. And this one is the comparing of the cardiac phases, from different cardiac phases, and we measure the RCA and LAD FFR value. So early systolic, the FFR value is very high, and in the end of diastolic it's almost same. But at the peak systolic it's decreasing. So with high peak systolic increase the FFR value, and decreasing the in diastolic and starting diastolic the FFR value is very high. So we see the same trending both in RCA and LAD. So this one I show the 4 cases of the mild cases, which showing this case, this one, and this one showing the blue one as a moderate. Normal, mild, moderate, and severe, and showing different phase of the early systolic, start early, peak systolic, and showing the trending. If we see this this one, you can see at the peak systolic it's very high, and going down notch again decrease, and in the diastolic shoulder it's showing high value also. So I show these 4 cases effect of the pulsatile flow. So this one is the section 3 is published in medical physics 1. Localized hemodynamic assessment. This is the detail about the mesh detail, number of the cases, mesh detail in which tetrahedral, prism layer and faces, and the simulation time and the current number we mentioned in this table. And this is the aneurysm in which we measure at a different, like the length of the neck, dome and width. So we get the area of the aneurysm and the volume of the aneurysm. So this map showing the hemodynamic variation over a pulsatile flow. In coronary artery we have a 9 point. In this one we using 5 P1, P2, which is a peak systolic, leg systolic, dichotic notch, peak diastolic and diastolic. So if we see the trending of parameters like wall shear stress showing very high, and when it's go to the in diastolic it's showing low. So it's showing the effect of pulsatile flow on the aneurysm. And so I show 2 cases here. So you can see both have a same trending, like if we see the wall shear stress, effect of the pulsatile flow. Yeah, so this one I showing the 10 cardiac cycle in 8 scan, the effect of the pulsatile flow on the intracranial aneurysm, and after that I show the cardiac cycle in 10 second slope, like how it's affecting with the pulsatile flow. In the same way, like I show the pressure gradient, vorticity, velocity and wall shear stress. So it's like a 10 cardiac and 8 second and 10 second 1 cardiac cycle. So after that we measured wall shear stress at specific location, like the extreme value of if I measure low wall shear stress, I measure at lowest one, and high wall shear stress highest one. So we measure at different location to see like 2 cases I show in the thesis. I show all the cases, like we measure this one. So when we measure this one, we see the when it's we measure at the lowest one, so the mean, maximum and average. So if the rupture is caused by lowest wall shear stress, then maybe the lowest we need to say like, okay, 4.5, less than 4.5 wall shear stress maybe cause the rupture of the aneurysm. If it's the high wall shear stress cause the rupture, then maybe if more than 20, or maybe average like is average is more than like around 12 or 13. So if more than high wall shear stress causing the rupture, then maybe after 12 PA maybe cause the wall shear stress rupture. So we measure all the parameter of the highest from previous image, like a highest extreme points. And when we comparing with the rupture and non-rupture with this parameter, the non-rupture low wall shear stress is very low, like in the non-rupture is 0.5. And in the rupture it's more than 1.5. When we see the rupture, non-rupture versus rupture in the high wall shear stress, then it's more than 12. Like this previous one, the average is more than 12. But if you see here, then in a rupture, non-rupture is showing more than 12. It means that if non-rupture is mean less than 12, it's okay, like it's not cause a rupture. But in the rupture case, it's showing more than 25. So in all parameter, I show like a high toss, what is the extreme, like causing in the rupture, which is around the 12, and in the rupture it's around 27. And the low toss it's showing like 0.5, and in the rupture it's showing high. So all this showing high, but when we see the pressure gradient, high pressure gradient in the non-rupture case is showing very high, and in the rupture is low. And high pressure in non-rupture is high and rupture is low. And same way like velocity, the non-rupture the velocity is low, and in the rupture case velocity is high. So this one is Tesla, why we call this Tesla framework in synergetics is a targeted evaluation of synergistic link in aneurysm. So when we find out try to find out the relationship, like if I find here high wall shear stress, and at this location I try to find other parameters like a pressure gradient, velocity, vorticity, then we get this kind of a Tesla shaped image. So we give this name as a Tesla, because in all cases like this one, when we see the high wall shear stress and we measure other like a toss with vorticity, it's Tesla, and it shows the same trending effect. And in this, when we measure the lowest wall shear stress, and like I measure 2 points, two lowest point, 1 and 2, and we compare. So in this one we get the like a bird like a flying bird shape in this one. But all the parameters of when we measure wall shear stress, toss and vorticity, it's showing same. But when we measure the OSI, but its OSI totally changed, like it changed the phenomenon, the shape. So it means it's not dependent on our following the same rule with others. So other is also following the same case. And if we see also like in the lowest case, the wing form is totally changed, like N1 is like a V shape, but this change is changing. So this one, fourth one, is the progressive flow abnormalities in cerebral aneurysm development. Comparative analysis of normal, blaster, secular and rupture hemodynamics. So in this one I showing first show the whole geometry that we simulated in showing the different parameters, like first one is wall shear stress, toss, OSI, pressure, velocity. So we comparing all things. So when we compare the rupture, scalar and blaster and normal. Basically blaster is not an aneurysm, it looks like an aneurysm. So we want to see is this causing aneurysm or not. It looks like aneurysm, but we try to simulate if it's aneurysm or it maybe cause aneurysm. So when we measure the whole geometry of the aneurysm, we get a different, like we measure the relative difference changes. So in the wall shear stress, when normal as our reference, so it's 21 blaster showing 21% increase the wall shear stress, and in the scalar aneurysm is showing 144 times increase, and in the rupture case the wall shear stress showing 223 times high. It's comparison on the whole geometry. In the same way, like if we see the toss is also increased with 4.4% and 0.33% in the scalar aneurysm and 37% in the rupture aneurysm. And the p-value except RRT is not significant. Other values are shown very high significant value. After that, we try to see the hemodynamics in the dome of the aneurysm. So we just not showing a normal one, so we just compare blaster, scalar and rupture aneurysm. So when we check the in this one we use as a blaster one as a reference. So the relative difference is 94% in the scalar, and in rupture it's showing the 252 times more in the rupture case when we only checking the hemodynamic in the dome. And in the same way when we check the toss is 4.3% and it's increased 81% in a rupture case. So also in this one RRT is not significant, RRT and pressure gradient not significant, other wall shear stress, toss and other showing very significant value. After that we also analyze the neck of the aneurysm. So when we comparing neck of aneurysm, it's comparing to the dome, the neck showing the more value changes, like wall shear stress with scalar blaster is 173.6%. and in the rupture case it's 309.4% increasing. And if I also see the toss, it's 60%, and change with the rupture one 120%. So in same case like RRT, it's RRT and velocity is not showing significant, but other values are showing significant. So let's discussion the first part. So the computational time constraint. The simulation took our 1 week per case due to the limited hardware and high grid density requirement. So in the starting I used this laptop, so it's not the hard disk like this, or RAM is not high, so it's taking a lot of time, 1 week. So now later professor gave me a computer, now we do it in 24 hours, one cases we simulated. So inversely relationship between FFR-CT velocity, severe stenosis cases had low FFR and high center velocity consistent with the paired CFD studies. FFR-CT and velocity, FFR greater than in the mild cases, less than 0.8 in moderate to severe stenosis, supporting established ischemia prediction cutoffs. Shorter measurement distance yield higher FFR-CTs. Longer distance reduce the distal pressure and lower the FFR-CT. And highlights the importance of centralized FFR-CT's measurement distance. So wall shear stress analysis, high wall shear stress observed at the stenotic region linked to remodeling and atherosclerosis. Low and oscillatory wall shear stress linked to the endothelial dysfunction, CVD progression and thrombus risk. Innovation and contribution, because in first one we use the open form, use to promote accessibility and cost-effective CFD simulation, and introduce non-invasive FFR based on the grading 0 to 5 for the coronary stenosis. Integrate FFR and wall shear insight for the holistic cardiovascular assessment tool. In a clinical implication, potential to guide the diagnosis, monitor and vulnerable region and personal treatment plan, and help in the early identification of the high-risk vascular region and intervention planning. Discussion 2 as part 2, like a CFD hemodynamic assessment. Use patient, before one is a steady flow and next we use the pulsatile flow. So the use patient specific coronary geometries from the CT images. Use CFD under the pulsatile flow condition revealed in the depth coronary flow dynamics. Demonstrated the potential of non-invasive CFD for clinical diagnostic and treatment planning. So velocity and the flow pattern, pulsatile wave velocity increase the downstream, especially in the distal LAD. Recirculation zone formed at the LCA bifurcation worse with the stenosis severity. Helical flow in the RCA associated with disease development. Pressure gradient inside, pressure decrease along the artery from proximal to distal regions. High proximal pressure due to the stenosis induced resistance. Non-uniform pressure gradient at bifurcation aligned with the common site of atherosclerosis. FFR-CT observation. FFR inversely correlate with inlet flow velocity. Lowest FFR-CTS in LAD suggestion high stenosis likelihood. LCX had highest FFR followed by the RCA and LAD. Vorticity and flow instability. High velocity at the bifurcation and distal LAD and RCA. Vorticity linked to the stenosis progression and risk for the plug rupture in YA cavitation. Wall shear stress, low wall shear stress promote atherosclerosis, high wall shear stress damage the endothelium. Pulsatile flow causes dynamic wall shear stress variation, especially at bifurcation and distal vessel. Wall shear stress is a critical biomechanical indicator of plug development and progression. So, TOS or OSI and RAT. TOS elevated at stenosis region indicate of vascular remodeling. OSI peak at bifurcation zone and RCA base potential plug formation site. RRT map recirculation zones and stagnation region indicating stenosis risk. So the limitation in here, the sample size is only 24 and 48 arteries. and small branch excluded for the simplicity because to the jet flow effect. We remove the small arteries, and arterial wall remodeling are rigid. Future work should including wall deformation. So the wall is rigid in our cases. So in future we need to make a elastic artery. So discussion third part, analyze 18 aneurysm from 15 patients using localized hemodynamic evaluation. Focus on aneurysm dome where extreme flow behavior and mechanism occurs. Elevated the effectiveness of Tesla framework for rupture assessment. Demographic and morphological, high prevalence in the female aligned with the existing literature. So the female has more aneurysm rupture risk. Most aneurysm located in the PCOM and ICA, consistent with the known as anatomical hotspots. Aneurysm shows significant morphological variability, emphasizing need for the individual assessment. Hemodynamic variation and rupture, pulsatile flow cause marked stress and turbulence, especially at the dome. Low wall shear stress associated with wall degeneration, high value to the mechanical stress and rupture potential. TOS, heterogeneity show the both stable flow and local stress peak. High OSI indicate oscillatory disturbance flow causing endothelial damage. High RRT mark flow stasis increase the wall vulnerability. Elevated vorticity and pressure gradient indicate complex high stress flow zones. Rupture aneurysm had higher maximum value of wall shear stress, OSI, RRT, vorticity and pressure gradient comparing to the non-rupture walls. So the Tesla framework enabled to integrate analysis of hemodynamic using radar plot and 3D visualization. Dedicated correct stress pattern, high wall shear stress and TOS aligned with steep pressure gradient. Low wall shear stress and TOS aligned with the high RRT. OSI and RRT had unique spatial pattern revealing distinct biomechanical roles. And deviation in Tesla shape flag area for concern, spotting utility in rupture prediction. Clinical implication and future direction. Localized hemodynamic mapping offer actionable insight for the rupture risk prediction. Tesla can facilitate the personal risk stratification and targeted treatment. Future research include more rupture case for the statistical strength. Conduct longitudinal study to the track hemodynamic change over time. Combine Tesla metrics with the clinical and image data for multimodal prediction model. So section 4 for the fourth part, key hemodynamic finding. Wall shear stress increased dramatically from normal arteries like 2.1 to 1 and rupture cases it's 9.0 and up to 234.7% in aneurysm. And rupture case aneurysm is 223.7%. In the dome, 252.63 increase from the blaster to the rupture cases. Neck rupture aneurysm had 309.43% high wall shear stress than blaster. Time average wall stress at the neck rose up to 125.4% in the rupture aneurysm. These trends confirm the chronic mechanical overload in the driven aneurysm progression and rupture. Turbulent flow and structure instability. OSI shear index increased by 38.9% at the neck and rupture case dome in the rupture case. Dome OSI peak 0.471 in rupture aneurysm. Vorticity surged by 231.2%, indicating high disturbance unstable flow. And pressure gradients, dome 718.98%, neck 447.01%. These changes suggest the pathological biomechanical environment leading to the wall degeneration and failure. Visual and spatial correlation, localized stress concentration at dome, neck and bifurcation, flow jet and geometric transaction aligned with the rupture point site. This reinforces feedback loop between the morphological and hemodynamic in disease progression. So in the clinical implication, velocity trending, blaster slightly decrease, minus 15.33%, secular is 226.5%, and rupture 348.6%. Mimic real-world patterns in clinical rupture events. Spatial overall between the high stress region and the rupture site point are predict utility for this parameter. Relative resistance time show wide variability, stressing to need for the patient-specific analysis. In the future direction, investigate threshold value for the hemodynamics to enhance the risk prediction development personal rupture model and integrate quantitative CFD data, morphological characteristics, and advanced imaging. Such model could guide surveillance frequency, timing of intervention, and targeted treatment strategy. So in conclusion, this study show how advanced image and computer simulation can help us better understanding blood flow patterns in both coronary artery and brain. In coronary arteries, we found that lower FFR values and high blood flow speed are the sign for more serious blockage, especially in LAD artery. In brain aneurysm, we discovered that as the aneurysm grow and get closer to rupture, these are big increase in wall shear stress, pressure, and flow distribution, especially in the dome and the neck areas. These changes may weaken the vessel wall and increase the risk for the rupture. Our results suggest that using this detailed blood flow measurement can help doctors more accurately assess the risk and create better and more personalized treatment plans. So again, I thanks to Professor. She always guiding me in research and to continue support, guidance, and supervision throughout these studies. That's complete this stage. And also my lab mate who always supporting me and teaching many things. So this is it. So welcome if any question.
So let's start the Q&A sessions. Please do it in counterclockwise, okay? Professor Huang， 教授先开始提问。
So I'm the first one, so I can answer the most simple one. So actually I'm not in the field, so I cannot give you some professional suggestion. But for your thesis format, I do have some suggestion. Okay, especially to fit the criteria from our department. First of all, your abbreviation should be alphabetically fixed. Yeah, you do not do this one. And second one is you have an IRB, right? I saw you write this protocol was approved. All the material you use from the clinic was approved by IRB.
Yeah.
It's better to show the number. Okay. The third question is about the figure lesion, especially figures 11 and 32. You write the figure 11 twice. Yeah, 32 also. And in most of the figures, so it's better to have a figures lesion title and then to describe the detail. For example, you have a multiple panel. Panel A is to describe the detail. But before each panel, you should have a panel title. Yeah, some of the figures do not have a lesion title. And about the measures and the statistical analysis, you do not have this session to write how to do the statistical analysis. Yeah, actually I do not see many yeah. So and next one is some figures you show in the thesis, like figure 1. This figure 1 is I don't know whether you draw by myself.
Yeah, I draw by myself.
Okay, so they will be okay. This I saw you a dead.
No, I just get the idea and draw myself.
Okay, this is good. And how about the graphic abstract? You have a 2 graphic abstract, right?
Yeah.
And both of them was already published in your paper?
Yeah, I only show in the published one.
Yeah, but if you wanted to use in your thesis, you also need to cite because the copyright already belong to the arbitrator. If you wanted to put your features in your thesis, you need to cite.
Okay.
This is just a simple question.
Next will be Professor Wu's comment.
Okay. Actually, I'm not an expert in this field as well, so forgive my very naive and stupid questions. So first, yeah, I would like to echo Professor Wang because in my department, the PhD candidates typically will include their published paper as appendices for reference because this helps us to know which part has been peer reviewed, which part have not. And also, we can know the similarity between the dissertation and your published paper. Someday, if you want to run for president, maybe, I'm afraid that someone will criticize you by this. So maybe you can consider to include your published paper as well. And yeah, my first question is, I understand your studies want to achieve the goal of personalized medicine, right? But take the part 3 as example. If we found aneurysm by maybe CT or MRI, the physicians always want to use coil to cut off the blood by angiogram. So how do you, so how does your simulation can help the personalized medicine?
Yeah. So if we using the coil, so we didn't know which part is weakened, right? When you pull in the coil, maybe it hits the weakened point and it's rupture. So we also can predict this area is very like these parameters. We can say, okay, this area is weak, so we need to be careful when you put in the coil inside.
Yeah, if we throw the coil in the very upstream, how about
No, while we need to fill in the aneurysm hole.
Yeah.
Yeah, so when we filling, it's weak, maybe it's rupture and cause the blood flow inside the brain. So when we filling the coil, we can say like, okay, this area is the weak point, so we need to get it. And if our so if therefore I try to make more specific location, which is causing the high value or low value. So find out which area is weakened. So even if before coiling, we can, if we know that the range is the value is high, maybe we going for the clip or surgery, anything except the coiling is suitable for it not because the wall thickness. And also if we know early like the weakness of the wall, we will say because maybe it's rupture tomorrow, so we can treatment plan for that.
Yeah, but I'm not a clinical doctor, so I don't know this information is fitting their daily job or not. Actually, I don't know. But my second question is, you use non-patient specific flow profile to predict this, right?
Not patient specific. We use waveform, same flow rate, but the velocity is different according to the patient in boundary condition. It's depend on the cross-section, inlet cross-section area, because every patient has different cross-section area.
Yeah.
So our flow rate is same and the waveform is same, but the velocity is according to the patient specific, like according to their cross-section area.
But in the very beginning, you mentioned you can use sonogram to know the...
In carotid okay, first paper that we use a steady flow. So there's no pulse style flow. Second one, in the coronary artery we use the pulse style flow that we take from one literature review that we use. And in intracranial aneurysm, we use the carotid Doppler. So we can get the waveform of the internal carotid artery. So that one we use as a pulsatile flow, so that we take the waveform and the flow rate from there. And the velocity is each patient specific, yeah, because we don't have each patient intercarotid Doppler.
Is there a huge variation across the patients?
Yeah.
About that?
Yeah, we need more patient if we want to make more get exact value or like a more accuracy lab.
Okay. My last question is you assume the blood vessel is rigid,
Yeah,
but this is not true.
yeah, that's what we in the future we want to do, make it pulsatile. So what is elastic, we want to make it elastic because controlling the elastic is not easy in the simulation.
Yeah.
So
So I'm curious, is it technically impossible or just very difficult to input this parameter into your simulation
it's
model?
difficult because there's many boundary conditions we need to control.
Okay.
Yeah.
Difficult, but not impossible.
Nothing is impossible. Take time and more. Yeah.
Okay, good. Thank you.
Yeah.
Okay, good. So next in my turns, Professor and Professor are very practical, so I'm going to ask you some solid questions, especially about CFD. Okay. Okay. The first one is in your CFD model, do you use turbulence model, and how do you justify it?
It's a laminar flow.
Oh, it's a laminar flow.
Yeah.
But I saw your slide. You mentioned turbulence in some part.
No, like turbulence showing like after stenosis, the OSI is very high because when it's a very high stenosis, the jet flow is very high and then making also like a turbulence flow. It's not it's showing like a OSI, yeah, high.
Okay, okay. Then you need to make it clear in your dissertation you are not using turbulence model.
Yeah,
you
yeah.
only
Laminar.
laminar. And based on you should also provide Reynolds number to justify. So
yeah.
Otherwise, people will question. Well, it makes sense in such a small blood vessel. Usually it's laminar,
Yeah.
but sometimes the pressure is so high. So especially in anyway, sometimes you need to quantify this number, Reynolds number, in your CFD simulation. You can base on probably the maximum velocities you find, use that to justify laminar flow model is appropriate in your case. Okay.
Sure.
Okay. And I also noticed you use OpenFlow, the flow solver. It's a very popular solver.
Yeah.
And how do you do your grid generations? How do you generate your mesh?
Meshing. Meshing also I do in the CFX.
Oh,
But
you
the
use
simulation
CFX.
is in OpenFlow.
Okay, so I saw the structure is unstructured grid, right? Mainly it's tetrahedrals
Yeah.
or tridiagonals in 2D, something like that, right?
Yeah.
So you are going to do since you use open form, so it's finite difference, right? It's not finite it's finite element or finite difference you use.
Finite element.
Finite element.
Yeah.
Okay, okay, yeah. Because you use unstructured grid, so
Yeah.
you use a finite element. And you use explicit, that means time forward, right?
Yeah.
Oh, okay, because you have so many grids, so implicit will be very time consuming. For how many periods do you usually calculate for a case? How many cardiac period?
Cardiac 3 cardiac failure.
Right. Okay. So usually, how long in computation for computer
Now,
users?
because it's upgraded, so it's taking 23, 24 hours, like 1 day it's taking for simulation.
Okay, so
Yeah.
that's okay. Okay,
Yeah.
it's not very time consuming. Okay.
Yeah.
So let me see. Do you think besides Professor Wu mentioned the compliance of blood vessel, but the blood flow is not actually Newtonian fluid.
Yeah.
So did you evaluate, usually it's non-Newtonian, but this Newtonian or non-Newtonian, does it affect those output parameters, those output indicators?
I think it's affected because it's totally different, but I not validate or compare this thing in my study. Yeah.
Okay.
I just do the grid independent tests like that for validation and the blood in benchmark for the blood flow, but I not compare the Newtonian and non-Newtonian for validation, its effect or not.
Okay, well, maybe in the future you can
Yeah,
you can do one case to see it affects or not. Sometimes affect little. Okay. Okay. So in your simulation of the in the coronary artery, also the brain aneurysm, you offer many parameter or indicators, right?
Yeah.
Are these parameters, they are all consistent? I mean, if you indicate, oh, that is bad, so every indicator also, they are consistent in indication?
No, like if I see the Tesla for one, that I try to compare this one, but the one is not like, you see like, yeah, when I see the OSI, it's not like OSI.
Oh, OSI is not.
Yeah, because it's showing all like same changes, but when OSI, like it's the same shape, but when I check OSI, it's totally different. So
I see. Okay. So they are not all consistent. Some indicators are not very good.
yeah, for
And which one is most effective or most sensitive, most accurate to indicate the good or bad of the flow?
I think wall shear stress is more.
Okay. So if you only take one, you will suggest using the wall shear stress.
Wall shear stress, yeah.
Okay, good. And in aneurysm, you do many calculations, and you do two kinds of aneurysm.
Yeah.
Can your model predict where, if it rupture, where it will rupture?
In my this research, I just can predict according to the value, but I don't have clinical data to compare because this is already rupture cases, so I don't know which location is rupture. So I can predict, I can say this area may cause the rupture,
I see.
but I don't have validation because I don't have clinical data to compare or validate.
Okay, so usually you will suggest the largest wall shear stress is the place to rupture.
Rupture in aneurysm, yeah.
And the largest wall shear stress usually happen at the neck or dome.
Yeah, it's in also like if we compare the neck, neck as high, but maybe it's helping to increase the size of aneurysm, but it's not causing the rupture because mostly rupture caused in the dome because it's expanding.
Oh, okay.
Yeah.
Okay.
Yes.
I see. Well, because you use rigid body, but since the flow is pulsated, sometimes the aneurysm will oscillate.
Yeah.
So that's will also have some effect.
Some effect.
Yeah. Okay, good. Okay, so that's the question I just asked. One more, I want to comment your research. I think it's very important also because nowadays for medicine, we try to develop so-called digital twin. So it's very important for the patient to have a digital twin. And your work can be related to the digital twin. So you do the CFD for specific patient, then you can provide those important indicators to develop. So it's, this is very important, also very meaningful. In the future, there's one direction you can work on is you can use the AI, like deep learning to start. So, for example, if you have a CT of a patient, without running CFD, just look at the morphology or geometry. Because you have done so many calculations, maybe just the morphology or the geometry, you can detect it is a severe disease, severe or not. Maybe it's a good way. Otherwise, each time you run the CFD, it will take a lot of time because before the running the solver, you need to do the gradient, many are pre-processing.
Yeah.
But sometimes the MD, the doctor need immediate.
Yeah.
So AI, I think AI will be pretty helpful.
Yeah.
Based on your knowledge and your data, you can do some AI, like a regression to see. You can just once CD is coming, you can just suggest it is severe or not so severe, all kinds of things. Okay. Okay. Good job. Professor Tsai.
Okay. So I think you do a very good job, and just have one or two small questions. So I see you tell us we can use 5 elements or medium elements, and it takes different time for simulation.
Yeah.
And we also see you have shown some error in page 50.
50?
50.
Or 15? Yeah.
And you choose some. So how can we show some error here, right? How can you tell us we choose 5 elements or medium elements influence on your final result?
Yeah. So basically, computational fluid dynamics depend on this meshing. If a good quality, the result more good. Like the convergent, we say the current number. Like in another table, I think one table I show the current number. So it should be less than 1. So we will check according to current number and other parameters. So when we check the meshing, the difference, like if you see to find two cores when we compare relative difference, it's very high. Although it's less than 4.5%, 4.15%, but it's very high. When comparing with to the medium and fine, the difference is only 1.3%. So it's not too much different. But if we see the time is so different. So for the simulation time to work more fast, we use this one. Even if you go for this one, that's will give you more good result. But it's take more time. Like this one show 93 hours and this one is 60C. But the relative difference is only 1.3%. So therefore we use the median one.
So how can we know 1% is no influence for your final result?
The difference is not that high, 1.13%. If it's more than 5, the simulation it's not converged, like it's not stable. It's depend on stability. So the difference is only 1%. Like according literature review, if less than 1, then it's okay. Yeah, less than 5 is okay. So we try our best to keep more good mess. Yeah.
And so another question is, you have how many cases you use in your simulation?
In the first one, coronary, we have 18. Then another coronary artery, we have 24. Then aneurysm one, we have 18 for first one, and second one is 42.
Okay.
Yeah.
And for so many people, you have many observed very ratios.
Yeah.
And some case may be extreme case or not.
Yeah. So when we generating the image, if the like sometimes the image, the artifact or the noise, we already exclude those things. Yeah. So those patients, like we exclude, like when we generate in 3D reconstruction. So for example, the rupture case, because the image is according to the blood. So the when blood and the artery mix, so we cannot separate that one in the rupture case. So we skip, we already exclude those kind of patients. Yeah.
So you have to do this process for the simulation.
Yeah.
Okay.
We exclude. Yeah.
So okay.
Already, Professor Shi will ask the question and comment.
Following Professor Hong and Professor Tsai, the core number is a crucial factor in numerical stability and convergence. Do you remember how much of your causal or fine element mesh size in core number change? Can you describe?
Core number
Yeah.
change between.
Yeah.
When I check in the porous number is 0.05. It's very low, but the core element number. But when in the median one is 0.16, and in the fine one is like 1.9. So there's the core number difference. So the like 1.69 and 0.16 and 0.19 not very much different, but the porous is 0.05, so it's not showing the stability.
Do you know the core number definition?
Definition? I can
Local velocity multiplied
velocity
Time interval.
times steps and this divided by I write here, I think. Oh, sorry. I cannot put the formula. Yeah.
But it's U data, DO data,
Yeah.
the common sense you need to bear in mind.
Yeah. I make PPT, but I forget to put like I show how this measure and.
Professor Hong said the lamina and the turbulence model. This model depends on the Reynolds number, but in general, if you use the laminar flow, usually the blood vessel diameter is less than 2 millimeter.
Oh,
It
okay.
depends on diameter of
Yeah,
the
yeah, I
vessel
think so,
size. Yeah. So but in some cases, the diameter is larger than this.
Yes.
So the laminar flow is appropriate.
Okay.
Especially for, I remember the maximum Reynolds number is around about 600.
Oh, that's
yeah.
not large.
Yeah.
Yeah.
Especially for in the intracranial
Yes, I see. Yeah.
cases.
Yeah. So you need to, if you didn't put it in your thesis, please write it down.
On the table.
Paragraph.
Yeah.
Justify the model, nominal model you use.
Professor Wu asked you one key question. Why is thumb and the neck? Because the thumb is especially for rupture. Because the wound is thick, becomes thick, so the rupture. In all these cases, all the rupture is emergent cases, so the physician has not the data give me, just the CT image before the treatment. So we didn't have the in real-time image.
So this echo the professor who said you need the immediately result once they get the CT image, right? So maybe you can apply AI or something to do that.
In a diagnosed abstract, the professor will say the neck, because the neck will affect the coil putting.
Yeah.
If the neck is a rich pathway, because if the neck is so cannot turn the corner put into the coil to accumulate the coil density. If the density is not enough, the recurrent will appear. Yeah. So the neck size is very important for neurosurgical treatment to determine the neck. So many, for example, the thumb and the neck size is very important. These characteristics parameters from the physician, Dr. Wu, neck.
Yeah, very good. Okay. So any more questions? No? Okay.